Hello, hello.
Am I audible?
Yes, ma'am.
Nani Education, Research and Patient Care, offering education in 10 PG departments and 2 PhD departments. The institute is also organizing regular conferences, workshops, seminars, webinars, training programs, journal collabs, and other academic activities regularly. Department of Kabbalah Amrazanisma, in addition, organizes various national and international days for the women welfare, for the women health. On the occasion of Azadi Ka Amrit Mahotsav, this institute is organizing a series of webinars. Almost all 10 departments have been given the task to organize at least 2 webinars up to 30th June. Department of Kabbalah Nisma has certain importance and relevance in terms that this department is purely dedicated to women health. Today's webinar is one of such series which are being organized under Azadi Ka Amrit Mahotsav till 15th August. I hope further this department will organize further webinars if needed, and will provide facilities. The institute will provide all type of facilities for spreading knowledge all over India and abroad about the works and research which are going on this institute. The topic selected for today is relevant and is practice oriented, and I hope this topic and the deliberations will benefit a lot to the participants, for PG students, also for UG students, and all those students from Unani colleges who have joined this webinar. I am give my best wishes to the success of this webinar. Thank you. Thank you.
Thank you, sir, for those
Thank you,
appreciating words. May I now, without any further delay, I would like to call upon our first speaker, Dr. Vishma Shetty. She is a professor, Department of Obstetrics and Gynecology, Rajajeshwari Medical College and Hospital. Presentation and prizes. She's been credited to number of presentations and prizes in conference. She has been awarded free paper presentation on epidemiology, Bullosa, second prize in Gnanavarsha 2007 and first prize in Gnanavarsha 2011 in Young Talent Promotion. She has an OBG gold medal for University for exam in RUHS MBBS batch 898-99. She has to her credit publications on role of ultrasonography in diagnosis of ectopic pregnancy with clinical analysis and management in tertiary care hospital. Photograph analysis of spontaneous labor in term and primigravida, Journal of Obstetrics and Gynecology. Acquired lymphangioma, circumscription of the vulva in International Journal of Obstetrics and Gynecology. Prospectives and practice of contraception in women, SAFOG journal in issue Jan 2016. Her special areas of interest are laparoscopy and high-risk pregnancy. Over to you, ma'am.
Yeah, I'm just sharing.
Dr. Vishma Shetty.
Yeah, I'm just sharing my slides. Excellent. Can you see my slides?
No, ma'am.
Slide share has not happened. Just a minute.
Ma'am, you need any help?
No, no, no. I've got somebody. You just not share.
Now we can see your screen, ma'am.
Yeah, yeah. But this is the one. Yeah. Now you can see. Can I start?
Yes, ma'am.
Yeah. Good afternoon, everyone. Today, they have given me the topic: recent trends in the uterovaginal collapse. So to start with, how I have divided my slide is like we are going from basic to the higher level. Why
Ma'am,
we
if
are
you can be
doing
a bit louder, please.
so is this is how much? Now you can hear.
Yes, ma'am.
Better, ma'am.
Now I'm louder and clear.
Yes, ma'am.
Yeah. So how I have divided my slides are, we are going from basic to the advanced surgeries in uterovaginal prolapse. Why we are going from basics to advances? Even in the recent guidelines, what they have proposed is basic surgeries are still in use for the uterovaginal prolapse because they have tried so many recent advances in the prolapse surgery, but so many complications are later. I will discuss those also. So still the basic surgeries are in thing for doing the prolapse surgery. So we should not even forget our basic surgeries in uterovaginal prolapse. So coming to the background, the pelvis encloses organs for storage, distension, and evacuation. So anything coming out of the vagina or anything which is protruding out is called as the uterovaginal prolapse. So uterus is normally anteverted and anteflexed. Version means the angle between the longitudinal axis of the cervix and that of the vagina. That is between the cervix and the vagina. It is called anteversion. Flexion is the angle between the longitudinal axis of the uterus and that of the cervix. So you can see here, this is the normal uterus. This is anteversion. Uterus is anteverted. You can see the uterus is falling back. This is called as the retroverted uterus. Why we are talking all these things is in case of prolapse, the uterus is usually retroverted. As I told, there are two types of prolapse. One we call as the genital prolapse and one is vaginal prolapse. Genital prolapse is the descent of one or more of the genital organs. It is not just the uterus. The uterus will pull along with its bladder, urethra anteriorly and posteriorly rectum and pouch of Douglas. So if any one of it is coming down through the introitus, that is called as the genital prolapse. Vaginal prolapse can occur without uterine prolapse. But the uterus cannot descend without carrying the vagina with. So this is our normal pelvic anatomy. As you know, uterus is in the center, anterior is the bladder, posterior is the rectum. In the prolapse, can you see it is anteverted and anteflexed? Can you see once it starts becoming retroverted, the axis is changed, the uterus starts prolapsing out of the vaginal introitus. Now, before going for the major surgery, what happens is in uterovaginal prolapses, the supports of the uterus will become very weak. That's why the uterovaginal prolapse occurs. So, latest what we are following is we are following Delancey classification, who gives 3 levels of vaginal support. And still, in the present day also, we are considering Delancey classification only for the supports of the uterus. So Delancey divides the supports of the uterus into level 1, level 2, and level 3. So level 1 is the cardinal or the uterosacral ligament. Level 2 is pubocervical and rectovaginal fascia. And level 3 is pubourethral ligaments. Level 1 is Macken-Dodds and uterosacral ligament, as you can see. Level 2 is pubocervical in the anterior and rectovaginal. Now, level 2 is fascia, pubocervical in the anterior and rectovaginal in the posterior. Level 3 is the most lower part of the vagina. So, anterior vaginal wall prolapse, as you know, if it has the base of the bladder, it is called cystocele. If it carries urethra, it is called urethrocoele. Complete, it is called cystourethrocoele. So why it happens, anterior vaginal wall prolapse? Because there's a weakness in the support of the bladder neck, uretrovesical junction, because of the weakness of the pubocervical fascia and pubourethral ligaments. So same thing in the, just a minute. So level 2, pubocervical ligament. So urethrocoele and cystocele is because of the level 2 defect. This is how we correspond Delancey along with our clinical examination. So as you can see, Delancey 2, we get the cystocele and the urethrocoele. Then middle compartment is enterocele and herniation of the POD. And posterior compartment is the rectocele. This one already I have discussed. Now coming to the degrees of uterine descent. First degree, the cervix descends below its normal level. Usually the cervix will be at the level of the spine. If it comes below that, it is called as the first degree. Second degree is between the hymen and the spines. It is called as the second degree. Third degree is if it comes out of the introitus. Procedentia is the whole uterus is out of the introitus. So first degree, slightly it has descended from the level of the ischial spine. Second degree, it has not come out, but it is between the spine and the introitus. Third degree, you can see the os of the uterus, that is cervical os, is outside the introitus. So this is how we divide into degrees. Wall prolapse means where the uterus is not there, that is after hysterectomy. So what comes after hysterectomy? Descent of the vagina. So top of the vagina descends. That is called as the wall prolapse. So for the prolapse, so first we have finished Delancey classification. Next we go, what is the next important classification prolapse is POPQ. It was given in 1996. POPQ system describes the location and severity of prolapse. It divides into 9 segments: anterior vaginal wall, posterior vaginal wall, external genitalia. So they divide into 9 groups. Coming to the etiology, why prolapse happens? The most common cause of prolapse is acute and chronic trauma of vaginal delivery, and in the old age because of the estrogen deprivation. So these are the risk factors. But what are the precipitating factors? Whenever there is a, why all ladies won't get, only few of them will get, because of the increased intra-abdominal pressure, or because of the traction of the uterus by any cervical polyp, obesity, smoking, constipation, wherever you are straining, these might be the other precipitating factors to develop the prolapse. So symptoms of the prolapse, I won't go. I think students will be knowing how the clinical presentation. Just for completion, main thing is they feel something is protruding out, and as it will drag the bladder, they'll have urinary symptoms. Why they'll have urinary symptoms is because in the cystocele there is a retention of the urine, so they'll have repeated urinary infection presenting as urgency and frequency. Then stress incontinence, that means when they cough or strain, whenever there's an increase in intra-abdominal pressure, there is a leakage of the urine. Then if there is a rectal prolapse, rectocele, they will feel heaviness in the rectum and constant desire to defecate because the feces would have been sitting in the rectum. Backache is also one of the common complaints in patients with prolapse. So how this slides are included for if postgraduates are attending, how to examine a case of prolapse. You can't do any surgery without doing any examination. So what and all points has to be seen when you're examining a patient with prolapse. So it is divided like this. First, you have to do the local examination. That is, you have to expose the part where you have to examine the patient and you have to just look at it. That is called as a local examination. Then you will introduce your instrument or speculum. Then you are going to do bimanual examination. Then you are going to introduce your gloved hands, one hand in the vagina, one hand on the abdomen. That is called as bimanual. As you can see, there are urinary complaints also. So you are going to see whether there is any stress incontinence. That is anteriorly. Posteriorly, you are going to see the tone of the pelvic muscle, how much the perineal body is weakened. So this is how, and which position. This is the only case where we are going to examine the patient in standing position. Otherwise, all the patients are always examined in the sleeping position, supine position. So why we are doing the maximum straining happens during standing. When the bladder is empty, that time you can see the maximum extent of the prolapse. Okay. So how we are going to see the pelvic floor tone? Place one or two fingers in the vagina and ask the patient to contract her pelvic floor muscle. Then you have to gauge the ability of the contraction of the muscle. How we are going to evaluate the bladder? For all the patients, you have to check for the urinary tract infection, post-voidal residual urine volume. We do it in the ultrasonography. Clinically, we are going to do the bony stress test. That means we are asking the patient to cough. If there is any leak of urine, you have to note it down. Next, what you have to do is 2 fingers, you have to press against pubic symphysis like this. Again, you ask her to cough. If there is no leak, that means stress test is positive. That is, with stress, there is a leakage of the urine. So if we just correct the cystocele, it won't serve any purpose. We have to correct the uretrovaginal angle, which is altered. Then you have to even test for the integrity of the anal sphincter. Only the special tests are included, which a postgraduate has to do while evaluating the case of prolapse. Tone of the levator anal muscle, anal sphincter, demonstration of stress incontinence. so much we are talking about prolapse. But as you can see, there are so many precipitating factors. Before going to the management, how we can prevent the uterovaginal prolapse. So during labor and puerperium, avoid premature bearing down. What do you mean by premature bearing down is before full dilatation of the cervix, you should not ask the patient to bear down. That will cause the baby won't come down, but it will weaken the pelvic floor muscle. Then avoid long second stage of labor. Then don't allow any tears. You have to give a incision. So what is the difference between tear and incision? If you are not doing anything, automatically the baby will come out, but with lot of tears in the pelvic floor muscle. There will be a multiple tears. But if we give a proper episiotomy, proper incision, so what will happen? Only the tear will happen in one line. And if you suture in proper layers, this will avoid prolapse in the future. And this is the thing, we have to encourage pelvic floor exercise for all the women who have undergone normal delivery. Which pelvic floor exercise? We have only one pelvic floor exercise, that is Kegels exercise. Okay, now wall prolapse. How we can avoid wall prolapses? Wall suspension with uterosacral and cardinal ligaments. Then deep cul-de-sac we have to obliterate. So there is no bowel which will come out of the vagina by known as Moskowitz sutures. Kegels exercise is a very important. Actually, there are so many articles on physiotherapy in prolapse. Kegels pelvic floor exercise is one of the most important. So how we are going to tell the patient? They have to voluntarily contract the levator ani muscle and keep it for 10 to 20 seconds. And then they have to relax it. So doing continuously like that, it will tone up the perineal muscle. Decubitus ulcer I won't go through. Pessary, just for completion's sake, I've included pessary. So where we give, it's a temporary method. So we usually do in a young patient during pregnancy or where future childbearing is intended and they don't want to undergo any surgery, or to promote healing of the decubitus ulcer before surgery. So these are the types of pessary. So coming to the management. So physical examination is a must. As I told, local examination, you can see what is coming out. Anteriorly it is coming out, it is cystocele, urethrocele, rectocele, enterocele. Then you have to see for bladder, intestine contents is there. Posteriorly, you have to see for the tone of the levator ani muscle. And then you are going to do the surgery. So what is the main thing of surgery? So one is anatomical repair and another one is the patient quality of life should improve. So actually we divide the success of the surgery based on two. One is anatomical success and one is what patient feels. So in the latest guidelines, what they have told is more than anatomical success, we have to see for the patient satisfaction. Sometimes we would not have done why it has been given so importance is anatomical success may overdo or overcorrect the surgery. So patient post-op, the quality of life may not be maybe little hindered because of the overcorrection of the surgery. So in latest guidelines, what they have told is in 2022 guidelines, the success of the surgery is based on the patient satisfaction rather than the complete anatomical repair. I'll deal with that also. Okay. So as you know, these are the surgical approaches what we have. Why I put this list is to tell still what is in and what is out and what is the latest. So coming to first main surgery, ward Mayo's operation. Whether it is in or out, it is always in. What that means? We are doing vaginal hysterectomy with pelvic floor repair. Vaginal hysterectomy, we have to see the prolapses happen to the vagina. So we cannot, whatever can be the recent advances, we cannot bypass this vaginal hysterectomy. So still now, vaginal hysterectomy is the approach for removal of the uterus. Coming to the pelvic floor repair. So what we mean by pelvic floor repair? Anteriorly, it is called as anterior colporrhaphy, as you know. Posteriorly, posterior colpoperineorrhaphy. Whether it is in or out, yes, definitely it is in. Still we are doing these surgeries, still it is not outdated. Next, coming to the sacrospinous colpopexy. See, the basic terminology is, if it is a hystropexy, sacrospinous hystropexy. Hystro means uterus is getting attached to the sacral promontory. So all these surgeries, wherever hystro word is used, that means it is used wherever the patient wants to conserve her uterus. For example, in a young patient or who wants the uterus to be saved. So that is called as a sacrospinous hystropexy. So what is this word? Sacrospinous colpopexy. That means the uterus is out, only colpo means the vaginal vault, colpus. So that we are going and attaching to the sacrospinous ligament. There are a lot of the thing which has got advancement done is only in this aspect. Remaining surgeries we are still doing, but the recent advances, whatever has happened, and like which is in, which is out, I'm going to deal later. So most of the things has happened in this sacrospinous hystropexy or sacrospinous colpopexy. To tell in brief, so now the latest thing what they are doing is whether we have to do this. So there are various routes here, because here there is a basically there's a prolapse to the vaginal introitus. So vaginal surgery carries a lot of importance. So whether we are going to do vaginally, or whether we are doing laparoscopically, or whether we are going robotically, or whether we are doing abdominally. Okay. So I will tell which method is better. So a lot of controversies have happened in this surgery. Next, Fothergill's of Manchester, whether we are in or out, it depends. Why it depends is, Fothergill's of Manchester we use wherever the uterus is preserved, where we want to preserve the uterus. So what I told, you can go for either sacrospinous hystropexy or you can go for the Fothergill. So it depends. But if consider more of anatomical repair, we usually go for the sacrospinous hystropexy. So it is like either you can do it, but better is sacrospinous hystropexy. Coming to the leaf force operation, definitely it is out. I will tell you why it is out, because it has got more complications rather than the relief for the patient. Earlier, when we used to do leaf force operation, like where the patient was not fit for surgery and all. So in this new era of anesthesia, the patient will become definitely fit because of the new drugs and all. So to repeat, Ward Mayer's operation with pelvic floor repair is there. Sacrospinous colpopexy. Further this, yes or no? Leaf forces nowadays is outdated. So just to brief, why I'm talking so much is the anatomy should be very, very clear in the case of prolapse. So coming to anterior colporrhaphy, I'll just brief what are the steps. Why I'm telling is because like studying is different, seeing picture is different, getting explained is different. So I'll just tell you what are the steps of anterior colporrhaphy. So anterior colporrhaphy is performed to repair cystocele, as you know. So I needn't tell, this is our basic this one, that patient is in lithotomy position. I think I have got pictures, yeah. So this is for the cystocele. So inverted T incision we put. So now basically you see for the, now let us see the anatomy. You are seeing like
Ma'am,
this.
your voice is too low. We can't hear you.
Now you can hear me.
Yes, ma'am, better.
Yeah. So till now you were hearing, no?
Yes, ma'am, suddenly
Yeah.
it got low.
Okay. No, I dropped my mic. Okay. Next. So what is below the vagina? Below the vagina is the fascia. You just see there are 3 walls. First wall is vaginal wall. Second wall is fascia. Third wall is bladder. So till what level you're going to do? You're going to do till the second wall, that is till the fascia. What is weakened in the cystocele? As you know, there's a weakening of the pubocervical fascia. Sorry, vesicovaginal fascia. that is fascia between the bladder and the vagina, fascia is weakened. So what you are going to support? Either same fascia you're going to support, or you can put an extra layer to give an extra support for the bladder. I think I'm clear. So in cystocele, we put an incision. I'm not, vaginal wall is nowhere related, it just covers our bladder from the outer world. That's it. Main our aim is to vesicovaginal fascia, we have to support it. So where is our vesicovaginal fascia support? Where it is attached? It is attached to the lateral pelvic wall or white line, arcus tendon fascia pelvis, white line. So this fascia, it is torn. So what we do is we get attached to the lateral pelvic wall and then we'll close this. So fascia we have supported. Where it is torn, we have taken and we have got suture to the lateral pelvic wall and then we'll close it. We are not touching bladder. Now what I told, something called the latest, I think 2001, it was recommended, and 2005 onwards, what they started telling, see, you're having weak fascia here, let us put a mesh here. Rather than our own fascia, patient's fascia attaching to the lateral pelvic wall, let us put a mesh there. So they started putting mesh. This is which root mesh? Transvaginal mesh. So they started putting mesh here and then they started closing here so that the bladder is well supported anteriorly. But by 2008, see, this was done without any studies. They just thought like hernia, how they repair, they put a mesh and they support and it will cure hernia. They thought same thing about the vaginal prolapse, uterovaginal prolapse. But mesh complications became more severe compared to the cystocele symptoms. So nowadays the vaginal mesh is totally outdated. Actually, it was the latest. It has come in 2005. But by 2009, 2010, it is totally outdated because complications have become more. Later, I'll discuss that. Okay. Just to tell you here. So this one I have told how we repair the anterior colporrhaphy. Okay. So as I told, there is a tear in the pubocervical fascia or vesicovaginal fascia. So we go and get attached to the lateral pelvic wall so that the bladder is well supported. That lateral pelvic wall is called arcus tendinous fascia pelvis. So I have almost told about what Mayo repair. As I told, it consists of vaginal hysterectomy, PFR, anterior colporrhaphy, colpoperineurrhaphy, sacrospinacis for the vault prolapse. Should I tell vaginal hysterectomy steps or should I skip it? Hello.
Yes, ma'am.
Should I tell vaginal hysterectomy steps or should I skip it and go to the sacrocolpopexy? Should I?
You can explain, ma'am. The participants are asking you to explain.
Okay, fine. I'll just tell how, like now. So as I told, so when we see a prolapse, we are seeing the how we are going to identify a prolapse. I don't know whether it is a vault prolapse. I don't know whether it is a vaginal prolapse. The thing is, you have to see the os of the cervix. This is the anatomy in a prolapse. If you're not seeing os of the cervix, that means there is no uterus. Simple. You can't remove a uterus or you cannot have a uterus anatomy without a cervical os. So now you're seeing in from the front like this. So what I told, anteriorly you have got a bladder, posteriorly you have got the rectum. So this is what vaginal wall, this is what vesicovaginal fascia. So what is between vesicovaginal fascia and uterus is the UV fold of peritoneum. So that once you open this, you're going to enter the abdomen. So through the vagina, these are the main thing is you have to open the UV fold of peritoneum. Once you open the UV fold of peritoneum, see, UV fold of peritoneum is open. So this is vaginal wall, the vesicovaginal fascia, UV fold of peritoneum, and then the uterus. Posteriorly, simple vaginal wall, fascia, pouch of Douglas. So once you open that, UV fold is also called as the vesicouterine fold. Utrovesical also we can call a vesicouterine fold. So once you do, if you put an instrument here, the bladder will be up. So nowhere while doing surgery, the bladder will come in between. And as you know, we have got 3 sets of ligaments. Once you open top and back, first pair we go for uterosacral ligament. Second pair is uterine arteries. So you are going to do uterosacral. Second pair is uterine artery, and third one is the tubo-ovarian ligament. So anterior colporrhaphy I have told, UV fold of peritoneum once you open, then you start doing the first clamp, second clamp is uterine vessels, and third clamp is fallopian tube. Uterus is removed. As I told, if you open the UV fold of peritoneum, you have entered the abdominal cavity. If you leave like that, what will happen? All the structures inside the abdomen will come out, intestines, everything. So you have to close the peritoneum. Then you repair the bladder, then you repair the posterior. Okay. Now, something called as the sacrospinous colpopexy. As I already explained, colpus means vaginal vault. So here there is no uterus, or after hysterectomy, you are going to suspend the vaginal vault. So all the ligaments in the vagina is weakened. So where we are going to suspend to the sacrospinous ligament. So it's used to suspend the vault. So there are 2 methods for it. Either you can do the vaginal approach, or you can do the open method, that is abdominal approach or laparoscopy approach. So if we are doing, see, basically what I told is vaginal mesh. So mesh, see what they are telling is, see, the ligaments are so much weakened in the prolapse. So native ligaments are weakened. Again, same thing, you go on fixing here and there. So definitely the ligaments are already weak. Again, there are chances of prolapse. So what they are going to, they have told, let us use the mesh. So there are various, so what are the routes? As it is a prolapse, you have a vaginal mesh, or you can use the mesh in the abdomen, open method, or laparoscopy. As already told, vaginal mesh, it has come recently, but it is out already discarded by all the experts because it has caused more problems than the help to the patients. So if you're feeling the ligaments are very much weakened, the patient is having recurrent prolapse, or she's having severe degree of prolapse, or her tissues are very poor, for example, in cholangiovalvular diseases, then go for abdominal method of apical suspension. So in that abdominal, that means you open it and you fix it to the sacrospinous ligament or to the sacral promontory. Okay. Now the latest what we have got is laparoscopy or robotic sacrocolpopexy. As I told, Manchester Fothergill, here what I think I'll skip this because it will become more of theory. So still, why I included this Fothergill's operation is still it is the thing we are doing. It is not still outdated. Okay, just for completion's sake, I'll just tell in what happens in Fothergill's is first we have to dilate the cervix. Why we have to dilate the cervix is here the main thing in Fothergill's operation is you are not pulling the uterus above. See, uterus has prolapsed. Uterus has come out. What you have to do is, through the abdomen, you have to pull the uterus and you have to fix it somewhere where it won't fall back again. Usually to the sacral promontory or sacrospinous ligament, they fix it. Now here we are not pulling the uterus above. We are doing the surgery in the vagina. So they are doing amputation of the cervix. Whatever the cervix is elongated, they are cutting the extra. So we have to put so many sutures. I'll explain to you. So first thing they do is the dilatation of the cervix so that our sutures pass through the cavity of the uterus. Then anteriorly we do the colporrhaphy. In bladder, what I told is inverted T, pubis vesicovaginal fascia. We fix it to the side and we close it. Then cardinal ligament is the most important ligament in the support of the uterus. So that we cut and then we suture in front of the cervix. And whatever the cervix which is below this Mackenross ligament, we amputate it. I'll just show the picture. See, can you see? Small incision only, inverted T we put here. Here cardinal ligaments will come, first ligament. That we will do. We can't do the uterine vessels. Uterine vessels means the supply of the blood vessel of the uterus is lost. So you can only, what you're going to do is, this ligament is weakened, right? So where usually the weaken happens in the center. So we can't pull it in the center. So we cut it and we ligate in the center so that this portion becomes very strong. And whatever the extra tissue, we cut it. So uterosacral is ligated and extra tissues we are cutting it. See, can you see? Anteriorly we are supporting it. So now the center portion is fully supported. So nothing will come out prolapse. And the extra cervix is cut. So that is Fothergill's operation. Okay, coming to leaf nodes, I just as for completion's sake did this. This has got no use in recent pelvic organ prolapse surgeries. It is only for theory, it is there. Coming to the posterior compartment. So posterior compartment, anything which has become new? No. Still we are doing posterior colporrhaphy to correct the tectocy. I'll just show the picture. I think I've not. Okay. So same thing. It is called as the colpoperineorrhaphy. Now, the thing which has been made very much controversial in pelvic organ prolapses, what about mesh? As you can see in hernia, we use mesh. Hernia is also same, no, like a prolapse only. Whenever you cough, the contents of the abdomen comes out through the opening, inguinal, femoral. So what they do is to strengthen the anterior abdominal wall, mesh repair, mesh repair. Then why not for the gynae surgery? As I told, it has gone into a lot of controversy. So why it has gone for controversies? Like main problem is mesh erosion. That means you have put the mesh. So mesh has got, how the mesh helps with the inflammation, everything, it will go and get stuck to the tissues. But in the vagina, what are the tissues? It is not just the vagina there. There's a bladder in the anterior, posterior, there's a rectum. So that mesh will erode the surrounding structure. In hernia, when they do anterior abdominal wall, there is no structure. Only you have got skin and subcutaneous fat. Even if it will go and fix there or whatever to the anterior abdominal wall structure. Okay. So main problem is mesh erosion. Now, what do you mean by how you avoid? Now I'll come to later with that. I have got another set of slides for all this mesh erosion. Before completing this, we will see what is how we avoid vaginal vault prolapse. Okay. Something called as the Meckel-Kuldoplasty. It is very, very simple. If you see this picture, I think you cannot make out. So I'll just explain this. So now we have done the hysterectomy. Okay. That's why the peritoneum is open like this. Then what I told, all our three ligaments are like this. One is our uterosacral ligaments. Then we have done uterine artery. Then here we have got our broad ligament. I think I'm clear. See, we have done hysterectomy. So we have got three stumps here, three stumps here. So what I told while doing hysterectomy, you can leave. Decline. Huh? I will see it. All Kahani. Sorry for the. So you can see first is complete uterosacral, second is uterine, and third is our broad ligament. So what we are going to do here is,
Ma'am, your voice is not audible.
just a minute. Okay, now it is audible.
Yeah, yeah.
So now what I told, which is the ligament which is very, very important for us in a case of prolapse, is our uterosacral ligament. So we have cut here. Where we require the support, we require the support in the center of the new vagina. Now the whole vagina is new cervix. Cervix is gone. Now I have to create a new cervix. Cervix is the big support of the uterus. So how will I create this one? What is our, which ligament is very, very important? Our whole surgery in a prolapse is for the, only two things are very important, our fascia and the ligaments. So here we have dissected the fascia. So fascia, we are supporting the bladder and the rectum. So this new part, what we are going to support with our Mackenroth's ligament. So what I told, Mackenroth's ligament always should come in the center. If it is in the lateral, it won't cause any support. We want support in the center of our vagina. So Meckel's, so what has Meckel's told is, you can do two things. One is internal, one is external. In internal Meckel's, can you see this blue line? From where to where it is going? It is going from the uterosacral ligament, posterior wall of the posterior rectum. Vaginal wall is this. Don't get confused. This is vaginal wall. This is rectum. Sorry, anterior wall of the rectum and another uterosacral. And then you're going to tie. If you tie, what will happen? These two will come near. This is called as the internal Meckel. External Meckel is, you're going to just pierce the posterior vaginal wall, uterosacral ligament, and then another uterosacral ligament, and you're coming out here. So what will happen? Again, the uterosacrals will come in the center. So what will happen? It will support the new cervix, and it will prevent whatever structure from the abdomen to come down, to avoid enterocele and the future vaginal wall prolapse. Okay, I think I'm clear with this. I think I'm very much clear with this. Okay, just a word about nulliparous prolapse. So why it is happening? Sometimes because of the connective tissue disorder. That means basically the patient's tissues are only very poor. So as I already told, where your own tissues are very much poor, or there's a recurrent prolapse, that is, we have to use the mesh. So here there is nothing called as the vaginal surgery. Only surgery which we can do vaginally is for the gift, where we do the amputation of the cervix. Otherwise, we have to do sacrohysteropexy. So you got the concept between colpopexy and hysteropexy. Colpo means where the uterus is not there. Only the colpus, or vaginal vault, you are lifting up. Here, the uterus we are lifting up. And as you know, Indians have done so many, this one, Purandare, Shirodkars, Khanna, sling operations. So now let us coming to the, so I have basically finished all the surgeries, whatever we do for the pelvic organ prolapse. Now coming to the current trends in the reconstructive surgery. So what are the controversies? What are the latest guidelines? I'm just going to, as a concluding slides. So transvaginal mesh versus native tissue repair. So how we are going to do the apical suspension, sacrospinous ligament fixation versus uterosacral ligament fixation, whether we are doing laparoscopy versus open surgery or open versus vaginal surgery. I think the concepts are already clear. I think these are the, again, the same slides have come. So this is the mesh which you can see. Okay, this is the mesh.
Load the fixation onto the anterior needle such that the tip is inserted through the slide. To insert the anterior fixation,
This is
Ma'am,
laparoscopy
audio is not clear.
sacrocolpopexy.
hold the needle first
Now-
against the place.
Better.
The needle should be inserted with the white line directly lateral to the bladder. Locate the placement about 2 centimeters approximately the medial border of the descending pubic ramus. Continue to advance the fixation until the obturator internus muscle.
Now, see here is what they are doing is they are inserting the mesh and they are fixing to the sacrospinous ligament.
Penetrate. Center marking of the mesh is aligned with the vaginal incision. This technique should be performed for both patients' sides. Fix the center of the mesh to the bladder neck with the sutures. Then the apical graft to the desired important patient's condition. Place sutures in the apices, leaving the ends for later attachment to the graft. Below the apical fixation tips, insert the needle into the self-fixating tip, and then load the needle into the curved plastic sheet, 2 to 3 centimeters from the ischial spine.
Now, why I'm showing is like this is how generally laparoscopy sacrocolposuspension is being done.
Load the fixation.
That you give the new slide. I'll just share another slide, 10 minutes more. Slide. Okay, another 10 more minutes. So to conclude the session, so what we understood is what is the current surgical management of pelvic organ prolapse and how we are improving the surgical outcomes.
Not audible, ma'am.
Now, okay. So
Okay.
these are my concluding slides. So most common sites, as you know, anterior and the posterior. So anything, whatever you're going to do, you're going to do the POPQ. And how what is our success is not just our anatomical repair, subjective should also symptomatically, they should be better. They should not go for any reoperation and complications of the operation should be the less. That is our aim of doing surgery. And as I told, the latest guidelines according to the IC Urology 2022 is that patient satisfaction is the very important thing and post-operative complication is the important thing which will tell whether that surgery is correct for the prolapse. Okay. And the latest one, we are going for the laparoscopy or the robotic approaches in the prolapse. Now, just for conclusion, so what we have done in anterior surgeries, anterior compartment prolapse, what is in, what is out? Conservative management, pessary, surgical reconstruction, everything is in. As I told, pessary in the case post-pregnancy, post-delivery patient. Surgical reconstruction, what I told is you are doing the anterior colporrhaphy. So which tissues we are using? Our own tissues or whether the mesh? So latest guidelines, you can use our own tissues for doing the anterior colporrhaphy. So what is my success rate? My success rate is patient won't have any vaginal bulge and her urinary symptoms are relieved. It is more than enough to tell that my surgery is successful. So how will I know whether POPQ carries a very much importance? Let us see. So POPQ, as you know, it is very complicated system for the pelvic organ quantification. So they divided it into optimal anatomical outcome. Second one is satisfactory anatomic outcome. So what I should approach, as I told so many times, I am not aiming that everything, whatever was there before her childbirth, she should have the same type of anatomical repair. No, optimal is not the thing. Satisfactory is the thing. So what is the satisfactory? Patient perception of outcomes. Patient satisfaction that there is no bulb and her complaints are relieved. That means my surgery is successful. So coming to the anterior colporrhaphy using mesh, already I told only very severe type or recurrent type. In those cases, mesh can be approached, but still it has become very much controversial. So, improvement of quality of life and patient satisfaction are now considered more important than the
Ma'am, we are not
anatomic
able to hear
success
you.
alone. Yeah, anatomic success alone. So, what I'm going to see post-operatively, there is no vaginal bulge. Overall improvement in the quality of life. So how I'm going to measure this? There are validated questionnaires for it, how the patient is feeling. Now, although the anatomic success of anterior colporrhaphy is inferior to that of mesh repair, it has some advantages of quality of life. However, whom we are going to consider the mesh for people who have got recurrence, in those patients, you can consider the mesh. So, as I already told so many times, use of transvaginal mesh is the biggest debate in the past decade. As I told, 2005 it came, but it has associated lot of complication, mesh erosion. Can you see 30%? That means 3 patients I operate, 1 patient will come with mesh erosion. The urinary tract infection, fistula formation. It has got good surgical outcomes, but what happens to the patient quality? Quality of life is totally gone. That's why the mesh repair has become too much controversial. So whom we are going to consider mesh surgery. So these are the things which you have to discuss before considering the mesh surgery. One is it's a permanent implant. So future repairs is challenging. And it will put the risk for development of new complications. Okay, patient has developed complications. So she wants the mesh to be out. Removal of mesh is also very difficult. And if you're able to remove also, may not be complete removal may not be possible and may not result in the resolution of the complications. So what you can do is mesh placed abdominally. This is whatever I'm telling is to the vaginal route. It has got a better success rate compared to the vaginal placed mesh. So this have become made it very clear. Transvaginal mesh has got a higher complication rate than the transabdominal mesh. So NICE guidelines 2019 latest should be considered as a final option for pelvic organ prolapse. In addition, when using a mesh, it is recommended that the patient be fully informed about the possibility of mesh complications. So, which patient you are going to do mesh repair? Severe prolapse or recurrent prolapse. So these are the only 2 indications we will go for mesh repair. Better to go for the abdominal compared to the vaginal mesh repair. Next is okay. Next is okay. Now what I told is just not correcting the anterior, posterior. You have finished your prolapse surgery. What happens if you don't do the apical, that is vaginal vault? You'll have vaginal vault prolapse. That is called as the apical prolapse. It's not just doing some whatever is coming out, you do it. Future, you have to avoid the vaginal vault prolapse. So recurrence after POP repair. So you have to do a apical prolapse surgery. So what they have told is clinically significant apical prolapse is virtually always present in cases where both anterior and posterior compartment prolapse is there. So whoever is having both the prolapse, they will have in future because their tissues are totally gone. So definitely they'll have vault prolapse. So proper suspension of the vaginal apex is a very important step whenever we are doing the surgery. So what surgery I told to prevent vaginal wall prolapse? Meckel's scaldoplasty, Moscovich procedure. So these has to be done. If there are big prolapse, you cannot just come out by doing anterior colporrhaphy, vaginal hysterectomy, posterior colpopeneurophy. You have to do the proper apical suspension, that is Meckel's scaldoplasty. So what is the latest in this? So it is called as the obliterative and restorative approaches. In restorative approaches, transvaginal or abdominally. Abdominally is the best, called as abdominal sacrocolpopexy. As I already told, that is our vaginal wall. We are going and attaching it to the sacrospinous ligament. So I think I already have covered this. So people who want the uterus to be preserved, that time the term is called as the hysteropexy. Here again, we are using the mesh and we are attaching the uterus to the sacral promontory so that the uterus is pulled up. So, okay. So there is a few controversial topics. I just finishing it. So either I should do sacrohysteropexy. That means just the uterus you're going to fix it to the sacral promontory, or you do total hysterectomy and then fix the wall to the sacral promontory. So still it is controversial. It depends upon what the patient wants. Next, mesh fixation already I have discussed. The controversy. So what do you mean by the, okay, which material I have to use next? So we usually use non-absorbable. We don't use the absorbable. It will get absorbed. Non-absorbable like Prolene we use so that we fix the vagina to the sacral promontory. Another one new suture has come called as a barb suture. That also we can use. Coming to the surgery for the posterior compartment prolapse. Posterior compartment prolapse, there is no controversy. Transvaginally, you're going to the posterior colpopeneurophy. So traditionally, rectovaginal fascia, posterior colporrhaphy, it is still the in thing. As I told, mesh repair is not done. So there is no more controversy for posterior compartment. Posterior compartment, you're going to do only posterior colporrhaphy, which has got excellent outcomes with lowest rates of recurrence. To conclude, in different cases, POP repair is achieved using slightly different techniques depending upon the surgeon's skills. The definitions of treatment success and study designs are diverse in the literature. However, goal of surgery is maximize patient satisfaction and return the pelvic organs to their original positions. Thank you. I've ended mine, I think.
Thank you, ma'am,
Hello.
for a
Thank you.
Thank you, ma'am, for an elaborative lecture from the basics of anatomy and uterine support to the detailed physical examination. You also took us through the various surgical approaches for prolapse repair from conventional to laparoscopic. You also briefed us about the guidelines, complications, controversies, and assessment of treatment outcomes. Ma'am, with your permission, there are certain questions in the chat box. Would I discuss, ma'am?
Yeah.
Pregnancy-related complications and its prevention after surgical repair of nulliparous prolapse.
What you want?
Can you throw some
I didn't
light
get
on the
it.
pregnancy-related complications and its prevention after surgical repair of nulliparous prolapse?
See, once you do the nulliparous prolapse, usually now what we are following is, in a nulliparous prolapse, we are doing our Indian method, sling operations. In the sling, we have got two types. Either we are using the mesh or the tape comes, or we are using our native anterior rectus sheath. As I told, the basically the problem in the young lady with the prolapses, her tissues are very much weak. So nowadays we are not using anterior rectus sheath as the sling. We are using a like Prolene comes as a sling. We use it and we attach to the anterior part of the uterus so that the uterus is lifted up. So all these patients, they have to undergo cesarean section if they have undergone nulliparous prolapse surgery, sling operation. Because again, once we leave her for vaginal, again the patient's prolapse will happen. So such patients better to go for cesarean section after the surgical repair.
Okay, thank you, ma'am. Another
Okay.
delegate is asking for is having a short cervix pose more incidence to pelvic organ prolapse?
No, short cervix is no. There's nothing called as short cervix. Everybody's cervix will be that much length only, 2.5 to 3.5 centimeter. In pregnancy, some patients will have cervical incompetence. So don't get confused between cervical incompetence and prolapse. Prolapses, organs are descending from the introitus. Shortened cervix or cervical incompetences, cervix is not able to hold the pregnancy. Got the difference? So don't get confused between those two.
Thank you, ma'am,
Anything else?
once again for
Yeah.
your precious time.
Oh, thank you.
Hope,
Thank you for the very good audience.
your cooperation
and-
in further webinars.
Okay, thank you.
Thank you, ma'am. Thank you once again.
Shall I log out?
Yes, ma'am. Thank you.
Okay, thank you. Okay.
Moving on to our next lecture. Our next speaker. Am I audible?
Yes, ma'am.
Yes.
Our next speaker, Professor Ismat Shamir ma'am, HOD Department of Ilmul Khabalat wa Amraz and Iswan, will be speaking on the Unani perspective of pelvic organ prolapse with evidence-based approach. Madam did her BMS and MD from Nizamia Tibbiya College in year 1995 and 2000. She has worked as a consultant gynecologist in a reputed hospital for 4 years. Thereafter, she is working as a clinician, researcher, and academician and teaching PGs nearly almost 18 years at National Institute of Unani Medicine. To her credit are 2 books in OBG, 50 research and review papers. She has guided 18 students as supervisor and 9 as co-supervisor. She has received the best faculty at NIUM award by the Unani Medical Association, Hyderabad. She is also felicitated with Mohsin Etib Award, Best Researcher Award, and Bharat Shiksha Gaurav Puraskar. She has attended various national and international conferences. She has delivered 18 lectures as resource person and presented 30 scientific papers. She is a member of International Advisory Board of SCOPE Database. She is a reviewer and editorial board member of International Peer Review Index Journals. Madam is also a member of FRC of NIUM. Over to you, ma'am.
Hello. I'm audible?
Yes, ma'am. Ma'am, please start the slideshow.
Assalamu alaikum. Good afternoon to one and all over here. First of all, I would like to thank our esteemed director, Professor Abdul Wadud sir, for giving us an opportunity to conduct the national webinar on Unani perspective and recent trend in the management of Nutu al-Rahim, that's pelvic organ prolapse. And you people might have heard in detail about deliberate lecture regarding the recent trends in the management of pelvic organ prolapse. Ma'am has explained in detail about the latest surgeries which can be performed if patient is having the pelvic organ prolapse. And now I will cover the Unani perspective of the pelvic organ prolapse with evidence-based approach. So the learning objectives of my talk is to understand the concept of pelvic organ prolapse and the different treatment options as mentioned in the Unani system of medicine, to learn from experimental studies the role of Unani drugs which can be used in the management of pelvic organ prolapse, to draw the conclusion based on evidence-based research. So the concept of genital prolapse is as old as Egyptian mummies. The pelvic organ prolapse refers to the loss of support to the uterus, bladder, and bowel, leading to their descent from the normal anatomic position towards output of vaginal opening. The prevalence of pelvic organ prolapse varies between 30 to 40% based on pelvic examination. In large epidemiological studies, 6 to 8% of the women report a sensation of mass bulging into the vagina. It's a very high prevalent conditions in the female population, which impairs the health-related quality of life of the affected individuals. POP may seriously influence the physical, psychological, and social well-being of the affected individual and is associated with the considerable resource implication for the health service. POP affects approximately 8% of the women, and the demand for pelvic organ prolapse is expected to increase by nearly 50% over the next 40 years. That is, the surgeries for the pelvic organ prolapse will increase by 50% over the next 40 years. Despite the prevalence and social burden of this disorder, researchers and surgeons are waiting for a universally successful and risk-minimizing solution to these disorders. A variety of surgical approaches have been developed and optimized over the last half century to enhance the durability, minimize the risk, and to shorten the recovery. However, the treatment of prolapse remains a matter of individualizing the patient's outcome while navigating the risk of hernia recurrences, surgical complications, and mesh complications. Let's see the Unani concept of pelvic organ prolapse. So the concept of uterine prolapse was first described by ancient Egypt. So ancient Unani physicians, they have described the concept of the pelvic organ prolapse. There are various synonyms for Nutu rahim, that is Inzalaqur rahim, Buruz rahim, Istirkha rahim, rahim ka nikal ana, Aql rahim, Nutu rahim. And the definition of uterine prolapse is it's a condition in which the uterus descends down into the vagina or out of the introitus from its normal level. Let's see the causes of uterine prolapse. The causes of broadly categorized in 3 types, that is external, internal, and obstetrics. External causes, it includes like fall from a height, lifting heavy weight, trauma to the uterus, forceful shouting or sneezing, jumping, exposure to the shock or fear. So ma'am has explained in detail how this external causes uterine prolapse. Basically, it increases, but it increases the intra-abdominal pressure. So increases the intra-abdominal pressure together with the reduced weakness of the pelvic floor muscle, they causes the prolapse uterus to descend down. The internal causes basically includes the abnormal accumulation of the balgam-e ghalidh, that is viscous phlegm in the uterine ligaments, which causes its weakness and leads to the uterine prolapse. Again, the prolapse usually occurs in old age women having excessive nutriments in their body. Sometimes the uterine ulcer causes disruption of the uterine ligaments, leading to the uterine prolapse. Istirkha badan, that generalized muscular weakness or connective tissue disorders. The obstetric causes basically it includes delivery, vaginal delivery. The single most important risk factors or cause for the responsible for the uterine prolapse. Difficult or precipitate labor, prolonged labor, unattended deliveries, big baby, forceful pulling of the placenta or the dead fetus. All these are responsible for obstetric uterine prolapse. Basically, all this causes trauma to the genital organs in the form of perineal tear or vaginal tear, thereby it weakens the pelvic floor muscle. As a result, the pelvic floor which provides the support to the pelvic organs, keep the pelvic organs in positions. So when there is a weakness of the pelvic floor muscles, the chances for the uterus to descend down into the pelvis. So the clinical features, as mentioned, the classical urethritis include the severe pain in the back, pelvis, and anus. The patient may have the dragging pain in the back, retention of the urine and feces because of the associated cystocele and the rectocele. Madam has rightly said that the vaginal prolapse can occur independently of the uterine prolapse, but the uterine prolapse is almost always associated with vaginal prolapse. The patient will have dribbling of urine or urinary incontinence. Once there is increase in the intra-abdominal pressure, the urine will leak. Fever because of the associated infections, generalized body ache, fear, tetany, shivers. On examination, you will find the mass per vaginum, feeling of soft mass or bulge in the vagina. Vaginal discharge may be because of the associated infection. Diagnosis on PV examination. If you're feeling the soft mass in the vagina, it confirms the diagnosis of the uterine prolapse. The uterine prolapse has to be differentiated from the uterine inversions. In uterine inversions, uterine inversions is a no doubt it's a very rare but a life-threatening complication in the third stage of the labor, where the uterus turns inside out. So the leading part in uterine inversion with the fundus, whereas in case of uterine prolapse, the leading part of the cervix and can able to see the os. Whereas in case of uterine inversion, as the leading part is the fundus, the os will not be felt. So the degrees of uterine prolapse, as mentioned in the classical Unani text, when the uterus descend down into the vagina, it is considered the first degree. Descent of the uterus outside the vagina is considered the second degree. When there is a complete descent of the uterus along with the associated cystocele and rectocele, it is considered as the third degree. Now, when you look into the management of uterine prolapse, as mentioned in the classical Unani text, the general instruction that has to be given to the patients with uterine prolapse includes the rest and reassurance. The patient should have the proper rest. Patient should avoid intercourse at least for 2 months. Avoid physical strenuous activities as well as shouting. Patient should avoid the home deliveries by untrained midwives because it causes injuries to the perineal tear. The proper perineal support will not be provided. The patient may have the perineal tear which may lead to the uterine prolapse. Encourage the patient to have an hospital deliveries. Patient should avoid immediate resume to the work and heavy weight lifting following the delivery. Avoid use of hammam and musakid because this will increase the metabolism of the body because of the hot temperaments. That's why it has to be avoided. And use of when you see the management of uterine prolapse, they have mentioned those drugs which act as habis and sardokush. As the uterus itself has a temperament of har ratab and har rutubat has to be avoided. That's why the use of barit push design and dawai has been recommended. Avoid use of item which causes sneezing and coughing because again it increases the intra-abdominal pressure which leads to the uterine prolapse. Use fragrant drugs and avoid unfeminine items. Like it is mentioned in the classical Unani text, the uterus has an affinity towards the fragrance. So the women are instructed to use the fragrant drugs like bushka, amber, saffron, kapoor, jasmine, rose, nilofer, so that the uterus may recede back to its normal position. Let's see the principles of the management treatment in Unani medicine. First, you have to use the Musile Balgham Adya for Tanha Badan because as the disease is mainly because of the accumulation of the balgham or viscous phlegm in the uterine ligaments, which causes weakness of the uterine ligament leading to its uterine prolapse. So first you have to go for Tanha Badan so that it can eliminate the morbid matter from the body, thereby it does the detoxification of the body. Then use Mulagin Hukka for Tanha Amma and Mudirre Bor Adya for Tanha Masana. So the basic intention behind doing the Talaqiyah Amma and Talaqiyah Masana is so that there should not be any undue pressure over the uterus, and the adequate space will be there for the uterus to revert, to replace to its original positions. Once you have done the Talaqiyah Badan, Talaqiyah Amma, and Talaqiyah Masana, you have to go for replacement of the uterus to its normal positions. Then, once you have replaced the uterus in its normal position, then you have to use Khabis and Mukhaffiya Rahim Adiyah to provide strength to the uterus, because the Mukhaffiya Rahim Adiyah will act on the uterus by providing strength to it and maintaining its normal temperament, whereas Khabit drugs, basically it constricts the uterine treatment and helps the prolapse to replace. Let's see what type of diet has been recommended if the patient is having a uterine prolapse. The diet allowed should be light, nutritious, and easily digestible. Preferably, it should be the liquid form, such as baza and neem brush, maul lehem, maul sheer, moong ki dal ka pani, maul fawake, and sabudana. And the diet restricted is usually food is avoided during the course of treatment because the patient has to be remain ambulation at least for 1 week. So the liquid diet is preferable rather than solid diet. Avoid spicy and the salty food. And Ilash with the various regimens that can be recommended if the patient is having a uterine prolapse. Basically include the Dalak massage, massage the uterus with Rogan Gul, mixed with Rogan Haluk and Galia. Galia is the fermented powder prepared from the drugs which are fermented or scented, whereas Haluk is the scent prepared from the fermented drugs, and that can be applied for the body so that it can give the scent. But then you are using the fermented drugs with an intention so that the uterus should revert back to its normal positions. Massage the uterus with Rogan and Shamili mixed with Zafran or Galia, that is perfumed powder. Hijama Mohajjim and Nari, that is fire cupping is recommended over the back. Similarly, dry cupping below the breast and umbilicus for longer duration so that the uterus may revert back to its normal positions. Well, once you have done the Talaqiyah Badan, Talaqiyah Amma, and Talaqiyah Masana, then you have to replace the uterus to its normal position. So the procedure, as mentioned in the classical Unani text, it shows that patient must lie in dorsal retractable positions, bowels and bladder must be empty. Then sterile soft wool is kept on the uterus, followed by the tampon soaked in Usara Akhafia or Khabit Sharab, that is cold wine, is placed over it. Further, the vulva has to be covered with fat soaked in vinegar and bandage is applied over it. You have to apply the bandage, vaginal packing followed by the bandage. Then patient is instructed to remain on bed at least for 2 days. Only liquid diet is allowed and cupping is applied over the lower abdomen. On third day, the tampon is removed and the fresh tampon soaked in Joshanda Khabit Adiyah is inserted, followed by luteal with the same drugs, that is luteal with the Joshanda of Khabit Adiyah. Further, it is followed with the absent with Joshanda Khabit Adiyah, especially the Istar, Habul As, and Golisub. Vaginal packing is recommended every alternate day to prevent further descent of the uterus and advise the patient to avoid ambulation at least for 1 week. We have replaced the uterus in these positions. Then Ilaj with Dawa, pharmacotherapy. For Talaqiyah Badan Balham, you have to use either ARG Tribudi or ARG Kib, Shahib Hansen, Habbul Neen, and Habbu ARG. All these drugs will eliminate the morbid matter accumulated in the body. Thereby, it does it detoxify the body. Following Talaqiyah Badan and replacement of the uterus's normal position, now you have to use those drugs which act as Mukhaffiya Rahim, with tonics, like Dawal Mist, Kurse Ambar, Sharbate Vad, Sharbate Kausuban, Johar Mohra, Habbe Jawahir, Habira Kausuban Ambari, or Majibu Motors. All these drugs usually act as a general tonic. It provides strength to the body. It also provides strength to the uterus. It acts as a Mukhaffiya Aza Raisa, and it eliminates the morbid matter from the body. Then There are various medicines that can be used locally for the treatment of uterine prolapse. When you see the literature of uterine prolapse in Unani medicine, the Unani physician, they have recommended more on local treatment rather than oral treatment. So this disease can be treated more with the application of the local treatment rather than the general or oral treatment. So the various treatment regime for the uterine prolapse, as mentioned in the classical Unani text, include like Pukna, Anima, with Rogan Zambak mixed with a small amount of Haluk and Galia. Again, Galia is the fermented powder. Haluk is the fermented powder prepared from scented drugs and it can be applied to the organs. Then you have to prepare the decoction of Shugufe Anar, Shugufe Mazu, Kharnub Ham, Astusuf, each 1 part, Sarupal half part, Ustukutu, Shugufe Babuna, each 1/4 part. Add 204 ml of Rogan as and 1/4 part of Rogan Zaitun in decoction and Pukna can be done with this decoction. Another nuskha for Pukna is Rogan Chameli Safed with little quantity of Galia. Then nuskha for Butulo irrigation include a small amount of Rogan Zafran has to be mixed with Rogan Zanbak or Rogan Gul, and then pour few drops of this mixture into the uterus. Nuskha for takmeek, it includes either takmeek can be done with Rogan Gul or akhahia soaked in water or usara tarasis mixed with sharab khabis as well as mentioned by this previous. Apart from Bokna, Nutul and takmeek, other regimens that can be used for the treatment of uterine prolapse like Physija Passeri, prepared from akhahia, sak and ramak, dissolved in khabis sharab, or Madbukhe Babul, Tarasis, Abbar Sab and Kharlu can be used as Physija. Usare Khars Tarasis and Sharab Afis. Another nuskha is Physija can be prepared with Joshandai As or Shugufe Anar. Akhahia Murmaki Kundur Ladan Gullar Barge As Gulesuk Adase Mukashar Mazu Subs. All these drugs are finely powdered. Physija is prepared with Sharab Afis, again cold wine, and soaked in Rogan and Borat or Rogan and Gul and used as Physija. So when you see this drugs, most of these drugs act as habis and to the fit. Thereby, probably it will help the prolapse to revert back to its normal positions. Then, Zimad or ointment, once the prolapse has been reduced, apply Zimad of the astringent drugs like Poste Anar, Tazimazich, Bullar, Postemokina over the pelvis. Even Nutul with Madbuk of these drugs is also beneficial in uterine prolapse. Similarly, there are so many nuskha for the Zimad can be used if the patient is having uterine prolapse like Babul, Tarasis, Bullar, Mazu, Akhafia, and Usar electricis, dump in Abe As or Abe Bar and apply over the pelvis in the maximum. Poste Anar, barley flour, silka with water and apply over the lower abdomen. Another nuskha is Babul ki Phalli, Tarsus, Nagarbuta, Abbulas, Akhafia, and Gullar, dumped in Sharab and Abbulas. Even Zimad with Bahrosa confidence the patient is having uterine prolapse. Then another regime is Abzan, that is Ispat. The nuskha for the Abzan is basically it includes Iskar, Habbul As, and Gulisuk. Or it can be done with Iskar, Gulab, and Mazu. Or use of As, Iskar, and Postenar, which has been boiled in Abe Kumkum. Or Abzan can be done with Joshandai As, Joshandai Mastagi, Joshandai Kumkum, Joshandai Mazu. The various nuskha for Hamul or Passeri includes either the Passeri can be done with Usare, Bokore, Mariam, as Pajari knows, or Habulas Push or Gulisuk Push can be used as Hamul form. Use of Sabak or Mastagi or Rohanegul, Budrogane Susan can be used in Humul form for decubitus ulcer on prolapse spot. Other regimens include like Zarur sprinkle, where the powder of these drugs can be sprinkled over the affected part, like use of Akhafia, Mazu, Gullar. All these are finely powdered and sprinkled over the ulceration of the prolapse spot and seems to be beneficial. Similarly, Gudi, that is fumigation, where the drugs will be burned and the smoke will be provided to the affected organs. Use of powder for fumigation or Bukure Madhyam with Srika Espitalinus can be used for healing. Whereas Nusuk is basically a semi-solid sticky compound that can be applied over the cloth and then the cloth can be kept over the affected organs. So Nusuk can be done with Aridajau, that is barley flour, or Masoor Musalle with other harvest drugs. And Ilash vinegar. So United Region, we have recommended that if you try and prolapse space to replace to its normal positions, or if there are chances for the decubited ulcers to develop, the hysterectomy is the only different options. They have mentioned about the prognosis that the disease can be treated easily if it is an acute stage and occurs in the young woman. Once the disease becomes chronic, it is difficult to treat. And if the entire uterus comes out of the vagina and the treatment is unsuccessful, the chances that the patient may die. And the complications for this uterine prolapse is the chances for ulceration of the prolapse part of the uterus to develop because of the exposure to the air. So this is about the concept of uterine prolapse as mentioned in the classical literature. Let's see what are the studies. Research studies conducted at 9 a.m. if the patient is having a uterine prolapse. So this was the study conducted by Amiruddin Farzana, the foreign student, to evaluate the efficacy of Acacia arabica in women with uterine prolapse. So here the women with first and secondary uterine prolapse were randomly allocated in 2 equal groups. In test group, Ahahia was used both orally in powder form and locally in hormone form. So orally 3 gram powder was administered in 2 divided doses, and locally hormone was given consecutive for 8 weeks, where the 6 grams of powder Ahahia dissolved in 20 ml of water. The hormone stored in this water was inserted into the vagina once daily at bedtimes for 8 weeks. And in control group, placebo was given for the same durations. In addition to this treatment, pelvic muscle exercise was advised to the patients of both the groups. Then, after the treatment, it was observed that Ahahia was effective to improve the quality of life of women with uterovaginal prolapse because Ahahia acted as habis, Mujaffif, Muhallil, and Mukhawir. Apart from that, Ahahia contains tannins. And this tannin, it has got a strong astringent property that helps the population of the protein constrict the ligaments, tone up the muscles, and helps the prolapse to revert back to its normal positions. So each and every nuskha of contains Ahahia, that is Babul ki Palli, as a treatment for uterine prolapse, the most common drugs for uterine prolapse. Another study which was conducted by Faziana Abdul Rahman to evaluate the effect of Botulism, Bubax malabaricum, and Hubbul as with this combination in uterovaginal prolapse, a randomized open clinical trial. Again, here, the woman who is having the first and second degree uterovaginal prolapse in the age group of 30 to 60 years were randomly allocated into 2 equal groups, A and B. In group A, 4 gram powder of Botulism was administered orally with pill twice daily. And in both the groups, local treatment in the form of absinthe with Dushanda Hubbul as 12 gram once daily was given for 8 weeks. So 12 gram of Hubbul as will be boiled in 1 liter of water. Later 5 liter of water will be added. So in group A, the group A patient received both oral 4 gram powder of Botulism and local absinthe with Dushanda Hubbul, whereas group B received just absinthe with Dushanda Hubbul. After the treatment, it was observed that both the drugs was effective in improving the quality of life of women suffering from uterine prolapse, as these drugs possess Habit, Mujaffif, and Mukhawir properties. Moreover, when you observe the chemical constituents of these 2 drugs, as the Botulism and Hubbul, they are rich in tannin, catechin, and flavonoids, which absorb the excessive fluid, constrict the ligaments, and provide strength to the pelvic floor muscles. All this may help the uterus to revert back to its normal position. Another study conducted by Bisma Naeem to evaluate the efficacy of Purpose Infectoria Oligos in the management of uterovaginal prolapse, a randomized controlled trial. In this study, the patient is divided into 2 equal groups. In test groups, is part with decoction of 20-gram powder of Mazul was given. Again, the Mazul 20 gram is boiled with the 1 liter of water. Later, you have to add the 4 liter of water. And in control groups, is bought with the common salt. 10 gram of common salt is boiled in 5 liter, soaked in the 5 liter of water. And the treatment is given for consecutive for 8 weeks. In addition, the pelvic floor muscle strength exercise was advised to the patients of both the groups. So after this study, it was observed that the Mazu, in addition to the Kegel exercise, is effective and safe in subject to improvement of uterovaginal symptoms. Thereby, it improves the health-related quality of life of the individual. This demonstrates that sitz bath of Mazu can be a better alternate herbal treatment for alleviating the symptoms of uterovaginal prolapse. So, as you all know, the gauze itself as a powerful astringent and styptic. And again, this astringent effect of the drug is because of this tannin content. These were the studies conducted at NIU. Let's see the history, what the previous positions they have recovered with the treatment for the uterovaginal prolapse. Cajon Preparis, the first textbook on gynecological in the medical history, described that the uterine prolapse was managed with a concoction containing grain, fruit, cow's milk, put together and then taken as it is. So the mixture containing the grain, fruit, and cows, and then it was taken as in the form of Vitalia. Ebers Papyrus, which is apparently a copy of an older papyrus, they have mentioned the use of various lotions, honey, fumes of wax for the treatment of uterine prolapse. Ibn Sina, he has described the etiology, symptoms, and management of uterine prolapse, and he has mentioned bath with alum water, that is sitz bath with the curry powder, beneficent in uterine prolapse. Zaharovi, the father of surgery, he said that if any organ was prolapsed and could not be reinserted or revert back, has to be removed from below. So he has recommended the patient who is having the uterine prolapse, patient should go for vaginal hysterectomy. Hippocrates, he has recommended to apply the dry cupping on both the buttocks and lower abdomen in the hope of getting the prolapse into place. He also advised to raise the footing of the bed and sponge the prolapse with cold wine until it was reduced. It was then supported in place with vaginal pessary, impregnated with the half pomegranate soaked in wine. So here, the rid of fruit of anar is soaked in wine and it was used as vaginal pessary. So the mechanical blocking of vaginal pessary was the most widely accepted treatment of genital prolapse till 18th century. Habib Abbas, a Persian doctor of great repute, he was the first to acknowledge the trauma, particularly the birth trauma, with a difficult and prolonged labor as the cause of genital prolapse. He advocated the treatment as manual reduction of the prolapse with the introduction of a wool pessary into the vagina. Then once you have applied the pessary, the thighs has to be crossed. This vaginal pessary is considered as a more or less remake of treatment for the 100 of the years afterwards. The latest pessaries have been originated from this concept only. Then Polybius described his treatment in his book by blocking the vaginal canal with astringent lotion, vaginal pad, with the sponge or half pomegranate so that the uterus will not descend down. Aurelius Cornelius Celsus, he has treated the uterine prolapse by astringent washes, application of medicated pessaries to prevent further prolapse. So wash of the uterus with the astringent drugs, Dushanta of astringent drugs, or pessary which has been prepared with the medicated drugs, like especially the Papis drugs. Soranus Appius, who is the father of gynecology, he has treated the uterine prolapse by amputation. He catheterized the bladder and gave an enema before reducing the prolapse. There should be adequate space for the uterus to revert back to its position. He packed the uterus for hemorrhages and performed hysterectomies for prolapse. Galen believed that genital prolapse could reduce itself, and he has used fumigation to vulval area to treat it. So in 19th century, many conservative methods were available for the treatment of genital prolapse, which includes like use of intravaginal pessaries to block the vagina, douches with the cold water, sitz bath, vaginal wash, surf bathing, as well as uterine gymnastic and massage. So uterine gymnastic, basically it provide a strength to the pelvic floor muscles. So the most common exercise is that the patient should lie on the bed. The leg has to bend at the knees and try to lift the pelvis above, so that it will improve the tone of the pelvic floor muscles. Thereby, it helps the prolapse to resolve back. Let's have a look on the evidence-based urinary medicine that can be used if the patient is having the uterine prolapse. Most important, I have discussed earlier that Ahapia, that is baboon. Studies has already conducted on these drugs and showed that these drugs is effective if the patient is having a uterine prolapse. So baboon is the most important plant. Almost all its parts are used in medications, including the root, bark, leaves, flower, gum, and pods. So the extract of the part or legume is known as Ahapia. It acts as a habis, mujaffif, muhallil, and muhawiyaraham. So the decoction of Ahapia is beneficial in urogenital diseases. It prevents leukorrhea and revert back the uterus and anus when they come out. It is also useful in istirha-e-rahim, uterine weakness, and it tightens the perineum if used locally. In any form, whether it is absent form or hormone form. Ahapia contain tannin, which has got a strong astringent property. So this activity of habis and habis, because habis property is mainly because of the tannin content, and tannin has got a strong astringent property. Mazu. So these galls are the most powerful of known astringent. Hence, the galls are applicable in all cases where the astringent medicines are required. Again, the galls has tannic and gallic acids. And because of the presence of the tannic and gallic acid, they are considered the valuable styptic as well as astringents. So absent with Joshanda Mazu is helpful in uterine prolapse, rectal prolapse, with chronic leukorrhea. Sofufenmazu is used internally to tighten the vaginal introitus. Galls are used mainly to restore the postpartum uterine elasticity and it will stimulate the contraction of the muscles. The decoction of the galls is used as douche in cases of uterine prolapse or as enema in rectal prolapse proves to be the medication. Again, the galls is considered, Mazu is considered one of the best drugs for uterine prolapse because of this presence of tannins. Apulas, that is Vitis communis. It is one of the oldest medicinal plants used by the ancient Greeks and Romans for a variety of the ailment. Even it is used in fragrance industries also. So the galls, Apulas berries, basically it possesses astringent hemostatic activities. They are valuable for uterine prolapse and lax vaginal walls apart from leukorrhea and menorrhagia. So absent with boiled extract of Apulas is beneficial if the patient is having Furuja Raham or Bipat, that is uterine prolapse, rectal prolapse, and as well as it is useful in Sanana Rutubati Raham chronic leukorrhea. So these properties is mainly because of the presence of bioactive constituents like Purush mainly contain tannins, sugar resident flavonoids, terpenoids, citric, and malic acids. So again, Apulas is the one of the best drugs for uterine prolapse. Botulism, Bombax malabaricum, the most commonly used drugs in day-to-day clinical practice. Which act as a muhawiyaraham, habit, mujaffif, rutubad. It possesses astringent and styptic properties. It provides strength to the uterus and drives away the rutubad raham. Most commonly used in day-to-day practice. Rumman Anab Tulipa granutum. It acts as a habis, rather mujaffif rutubad, mukafi aza, mawalid food. So, Rumman juice is useful to resolve the infected wound. Gullar is useful in Sananu Raham. The rind of fruit is used in uterine disorders. Roganegul in combinations with other drugs is used locally in the form of Nutul, Takmid, Tuzija in uterine prolapse. Absent with Joshanda postenar is useful to prevent HMB as well as leukorrhea. So this habis habit property is mainly because of the bioactive constituents like tannic, ellagic acid, humic acid, gallic acid. apart from other constituents. So even most of the hukmas, they have recommended the vaginal pessaries prepared with the rind of fruit of anar. Gulisuk, Rosa Damascena. It acts as Muqawwi Raham, Qabid, Muhallil Aura, Mukhrij Madda Khalis. So it has dual properties, like fresh flowers are hard, bitter in taste with mild acidness and sweetness, giving it positive property. While dried flowers are sad and tasteless and possess Qabid property. Despite most of the hukma, they have recommended the Gulisur Khushk has to be root if the patient is having a decline prolapse. So Gulisur in the form of Fumul or absent helps to relieve the Salanur Raham, Darde Raham, offensive vaginal discharge, and it tightens the vaginal orifice. Sharbat Gulisur strengthens all internal organs, including the uterus. So these properties is basically because of the presence of the bioactive constituents like flavonoids, alkaloids, electrolytes, tannins. All these are attributed to the curative properties of this plant. And again, Gulisur Khushk can be used in any form, whether it is locally or orally if the patient is having a prolapse. Murmakki, Compliflora birra. It acts as astringent, hemostatic, anti-inflammatory, analgesic, apart from other activities. So this Murmakki is used in combination with other astringent drug Aspergilla in uterine prolapse. It is beneficial in Darde Raham, Varme Raham, Salanur Raham, Salabate Raham, almost in all menstrual disorders. So according to me, it is considered as a drug of choice for all gynecological disorders. So this properties of Murmakki is basically because the presence of the bioactive constituents like volatile oil, ricin gum, phenol, tannins, saponins, flavonoids, glycoside. So this drug is considered as a alternative to all modern medicine that can be used for gynecological disorders.
900.
Use of
तो
zaitun.
material अच्छा है.
Rogan zaitun is used in combination with other drugs, locally in the form of prolapse, because it acts as an antioxidant, antibacterial, antiviral.
Green pant की दुपट्टा है black है.
Plain pant.
हाँ plain रहता.
So this action is
देखो
because
हेल्प
the
लेना तभी
presence
भी
of
लेते थे. तो
hello.
हाँ उन्हें सेल नहीं हमें बोल को हमारा वाला ले रखते हैं. हेलो.
Yeah, there is disturbances.
Sorry ma'am.
Okay. The use of babona or chamomile. Again, babona it acts as a muqawwi. Mohlele para for salabat. If used in the form of zima the takti, muqawwi dimag, apart from other activities like antimicrobial, anti-inflammatory, antioxidants. So decoction of babuna flowers in combinations with other drugs is used in the form of hukna for uterine prolapse. And this again, this properties is because the presence of the bioactive constituents like steroids, phenols, phytophenols, volatile oils. So babuna can be recommended if the patient is having uterine prolapse. Use of saffron, that is saffron. Saffron basically acts as muhallil, muqawwi, ahsha, mujaffif, mulatti. So pessary of saffron is useful in painful condition of the uterus. Rohan saffron is used with rohanegul in the form of protein for uterine prolapse. Because both are fragrant drugs, so that can be helpful for the prolapse to revert back. Pessary prepared with equal quantity of saffron, afure, and touch mixed with rohanegul is used to treat the uterine diseases. Saffron it strengthens the internal organs because of its quvvat-e khabiza and aromatic properties. It is beneficial in the treatment of other ailments concerning the women such as leukorrhea and hysteria. And this action is again because of the presence of the bioactive constituents like terpenes, procitins, and other esters. Use of bartang, that is plantagol and sheleta. So zimad of bartang in combination with other Qabid drugs is used in uterine prolapse because it acts as habisafone, anti-inflammatory, musakina dard, antioxidant as well, because the presence of bioactive constituents like phenolic acids, flavonoids, and coumarins. So bartang is also one of the best that can be used for this Qabid property. Kazmazid, that is tamaric singolica. It acts as habisuddam, radi, and mujaffif. Basically, it is indicated If the patient is having Farouj Abafat, that is rectal prolapse, Sananu Rahim, as it is beneficial in rectal prolapse, so it can be recommended if the patient is having uterine prolapse as well. It is beneficial in Sananu Rahim orally in powder form and locally in the form of humol or RC. Fumigation with Cazimazid is effective to regularize the menstrual cycle and all types of inflammation, particularly vulnerability. Even it is useful in the tanning industry because of its high tannin content and also provide a coloring substance suitable for dyeing fabrics. And the activities is because of the presence of the bioactive constituents like tamarix, tamarixin, flavonoids, saponins, phenolic acid, tannins, and fumarins. So, Shibiyamani, alam, pitkari. It acts as habit, habisuddam, Rutubad, receptin as well. So, Sirspart with decoction of alum is used in rectal prolapse, uterine prolapse, even its powder is sprinkled over the anus. Douche prepared with alum water is useful in pruritus vulvar, vulval irritation, leukorrhea, and to tighten the vaginal introitus following the delivery. It diminishes the secretions and blood supply to a part by constricting the small vessels and organic fibers. It is therapeutically used in various diseases like leukorrhea, hematuria, hemoptysis, menorrhagia, and other hemorrhages. So, alum basically it is the most commonly used day-to-day practice. Any patients presenting with leukorrhea, vulval irritations, prolapse, do Sirspart with the sulfazide is usually recommended. Tabashir, Bambusa arundinacea. It acts as a habit, mujaffif, mubarid shadid, and mufarrihal. And it is useful in leukorrhea, spermaturia, bleeding piles, bilious diarrhea. Beneficial in high fever and sojisha asha, tasqina, atash. Tabashir in combination with other drugs is used in the form of Visaja in uterine prolapse. Traditionally, the bambusa leaves, shoot and seeds, root are used as astringent, laxative, diuretic, and the rest, and its extract acts as astringent, anti-inflammatory, antimicrobial, and anti-ulcer. Because the presence of bioactive constituents like tannin, phenols, sterols, carbohydrate, and amino acids. Mastagi, Maxticum. Again, Mastagi is an important drug of Unani system of medicine which has various pharmacological actions and therapeutic values. It acts as carbon, habisuddam, jazibe rutubad, mohdele aura, munafise balhab, jari. Because the presence of bioactive constituents like resin, volatile oils, terpenoids. It is used in zofemeda with gulkan in the form of ziva to resolve inflammations and in bleeding conditions such as hemoptysis because of its habis property. So, Mastagi is used in uterine prolapse in combination with other astringent drugs in the form of Sirspart. Kharnum Shamil, that is carob tree. It acts as Habis Shadid. Habis is Hal Mosanadepon, Mokhabiya Meda, Mohammed Ahram. It is used mainly in chronic and bloody diarrhea, chronic cough and chest pain. Local use of Kharnum in passary form, it prevents leukorrhea and heavy menstrual bleeding. Powder prepared from Kharnum seed is used in the form of Zarur and it is applied over the rectal prolapse. Absent with Jushada Kharnum, it prevents rectal and uterine prolapse. Even oral intake of single seed of Kharnum acts as a contraceptive for 2 years. So it I practice a Khabis Shadid, strong astringent, mainly because of the bioactive constituents like amino acid, gallic acid, phenol tannins. So again, it is one of the best for uterine prolapse. Apart from this, the common formulation that can be effective in day-to-day clinical practice for uterine prolapse include Majuna Moceris, Majuna Mufaggiraham, Sharbate Habulas, Kursekushta Marjan, Kursekushta Sada, Safofazaj, douche hormone absent prepared with the mixture of the carbon drugs can be used in day-to-day clinical practice. So in conclusion, pelvic organ prolapse is a common health problem affecting up to 40% of the Paris women over 50 years of age with significant impact on quality of life for the individual. It is one of the 3 most common reasons for hysterectomy in USA, accounting for 15 to 18% of the procedures in all age group, and it is the leading indication for hysterectomy in post-menopausal women. The treatment modalities for POP includes both surgicals and non-surgical procedures. However, these modalities are associated with many complications and drawbacks. The identification of a high-risk population could allow a focused modification of the risk factor such as obstetric events by recommended delivery by cesarean section. A similar screening process, including recognition of levator ani defects, could be followed pre-operatively to assess the risk of pelvic organ prolapse, recurrences, and mesh complications. Herbal medicine is the mainstay of about 75 to 80% of the world population for the primary health care, mainly in the developing countries. It's mostly because the journal believes that the herbal drugs are safe without any side effect, being cost-effective and easily available. The WHO said that the use of the herbal remedies throughout the world exceeds that of the conventional drugs by 2 to 3 times. In the system of medicine, there are reports of many single drugs and compound formulation for pelvic organ prolapse, possessing the properties like Harbis, Nijafri, and Bufavirenone. In Unani system of medicine, effective treatment is available, but the experimental studies were conducted on the few Unani medicine that took on the small number of patients with variation in the dosage and duration of treatment. Hence, future trials are recommended on the large sample size for the longer duration to prove the efficacy and safety of the Unani medicine. Moreover, other treatment regimes, as mentioned in the Unani classical text, apart from homolinapsin, can be implemented in day-to-day clinical practice, followed by research study of the particular regime to prove efficacy scientifically. Thank you for patience.
Thank you, ma'am, for the detailed presentation. Am I audible? Hello?
Yes, ma'am. Yes, you're audible.
Yes, ma'am.
Thank you, ma'am, for the detailed presentation on Nutu Al-Rahim. You highlighted us the etiology as per Unani concepts and gave us a detailed description of various treatment regimens, including both or Ilaj bid Dawa as well as Ilaj bid Tadbir. Your evidence-based presentation gives us the confidence of practicing Unani medicine as a non-surgical treatment option wherever feasible. Thank you, ma'am, once again. Ma'am, with your permission, can I take a few questions? Ismat, ma'am?
Okay, then go ahead.
Oral intake of Kharnab act as a contraceptive. Will you please put a light on this? How to use, in what dosage form?
See, it was mentioned in the Khazanul Adwiya that the single seed of Kharnub the patient takes, it acts as a contraceptive for 2 years.
Not audible, ma'am. Clear, not clear.
Hello?
Yes, ma'am. Switch on your video, ma'am, if works.
Hello?
Yes, ma'am.
Yeah, it was mentioned in the Unani books that if the patient take a single seed of Kharnub, it acts as a contraceptive for 2 years.
So how can it be used in case of prolapse and what precautions needs to be taken? Or in what dosage form it will be safe?
So that was mentioned as an oral intake of single seed. Oral intake of single seed of Kharnub, patient if she takes, it acts as a contraceptive for 2 years.
Okay. Thank you so much, ma'am. They have asked that in Unani, inversion and prolapse both have been mentioned in the same heading. Kindly help us differentiate.
No, they have not mentioned the inversion and prolapse the same headings. Both are different.
Maybe in some books they have taken.
Like prolapse is mentioned under the heading of Inzanafur Rahim or Nutu Rahim, And inversion is mentioned under the heading
Okay.
of inqalabur rahm. Inqalabur rahm, it is turned inside out. Inzalaqta, it is coming down. Descend
I
down.
request the concerned delegate to please refer the classical
Yes,
texts of
definitely.
unanimous. Thank
Yes.
you, ma'am. And herewith, I also take the privilege of proposing vote of thanks for today's webinar. I thank Almighty God for enabling us to successfully conduct this webinar. At the outset, I would like to thank our director, Professor Abdul Wadud sir, for providing us the opportunities and facilities required for conducting the webinar. I thank today's speakers, Professor Vishma Shetty and Professor Ismat Shamim ma'am, for enlightening us from the core concepts to recent trends with evidence-based data. I further thank organizing chairperson, Professor Ismat Shamim ma'am, and organizing secretary, Dr. Rashia Sultana madam, for such an informative webinar. I thank Ms. Kubra, system admin, for technical support. I thank all of PG scholars for actively participating in the webinar preparation. At last, I thank all the delegates for making this webinar a success. Once
Thank
again, I thank you all for those directly or indirectly involved in conducting this webinar and making it a success. Thank you all. Thank you.
Thank you, Professor, for doing the moderation from the home. Thanks a lot.
Pardon, ma'am?
Thank you for doing the moderation from home.
Thank you, ma'am.
Thanks. Okay.
Thank you so
thanks.
much.